Hello, everyone, and welcome to the Secondary Prevention and Cardiac Rehab Conference. Thank you for joining us today. Today, I am very excited to introduce our three presenters. First, we'll hear from Mr. Adam Schultz presenting a case study. Adam is a clinical exercise physiologist in the Division of Preventive Cardiology at Mayo Clinic in Rochester. He has 2 certifications from the American College of Sports Medicine, the clinical exercise physiologist and the cancer exercise trainer. He has over 10 years of experience in academic and applied clinical exercise physiology roles, and he essentially developed the Mayo Clinic Rochester Cardio-Oncology Exercise Program. As many of you know, he's been an invited speaker for numerous national and international conferences, with his presentations focusing on exercise interventions for individuals with a history of cardiovascular disease and cancer. And his 2 areas of interest are resistance training strategies for special populations and exercise prescription for patients undergoing cancer therapies. Then we will hear from Dr. Suarez Pardo, who's an assistant professor of psychiatry and currently a fellow in the clinician investigator training program at Mayo Clinic. She's working on a qualitative research study that aims to better characterize areas of psychological distress in patients with heart failure. She's also looking at identifying psychosocial risk factors and characteristics in patients with myocarditis and their caregivers. She earned her medical degree in Bogota, Colombia, where she's a licensed general practitioner and where she worked after completing medical school. She then completed a research fellowship at Massachusetts General Hospital in cardiac psychiatry research program, and subsequently completed psychiatry residency and a consultation liaison fellowship at Mayo Clinic. Her clinical interests include psychocardiology and transplant psychiatry, and her line of research has centered on psychocardiology with over 20 publications. Dr. Suarez Pardo has worked closely with the Latinx communities and actively engaged in equity, diversity, and inclusion education and practice. Then we'll hear from Ms. Kelly Pasalacqua, who is a licensed clinical social worker and has been practicing for 29 years. She's worked at Mayo Clinic for 24 years and continues to witness the impact of serious health conditions on patients and families. Kelly joined the Mayo Clinic Center for Congenital Heart Disease in July of 2019 to spearhead the social work aspect of patient care. Prior to this, Ms. Pasalacqua worked with pediatric oncology patients and their families. She's participated in several national academic presentations, participated on many Mayo Clinic professional committees, including the Mayo Clinic Pediatric Ethics Council and the Mayo Clinic Pediatric Palliative Care Team, as well as receiving the American Cancer Society Oncology Social Work Training Grant from 2011 to 2018. She's also currently a member of the Adult Congenital Heart Association and the Marfan Association. So with all those introductions, I will turn it over to Mr. Schultz, who will start with our case presentation.
All right, thank you, Dr. Bonikowski, for the introduction and the opportunity. Thanks in advance also to our main speakers today. So the case I'd like to highlight today focuses on a 64-year-old divorced male, father of 2 adult children. His past medical history is positive for combined systolic and diastolic heart failure, as well as emphysema. His risk factors included age and gender, hypertension, current tobacco use, alcohol use disorder, although he had quit within the previous 3 months, and stress. He did not have any psychiatric history or cognitive status concerns. The patient was experiencing progressive dyspnea and decreased exercise tolerance. He was actually only able to walk about 25 yards before needing to stop and rest. He was eventually admitted for AFib with RVR, rate of in the 130s, in the setting of decompensated heart failure and tricuspid regurgitation. He was also experiencing episodes of non-sustained VT and was discharged with a life vest due to concern for arrhythmia. He enrolled in home-based cardiac rehab 15 days post-discharge due to the public health emergency. Otherwise, patients typically need to wait at least 6 weeks before enrolling if their entry diagnosis is heart failure with reduced ejection fraction. At the time of enrollment, he wasn't performing any structured exercise, only activities of daily living. He was non-compliant with his medications. And on the first of 12 telephone visits with an exercise physiologist, we administered the PHQ-9 depression screener. He unfortunately scored 27 out of 27, which is indicative of severe depression. And he did reveal he had thoughts he would be better off dead or hurting himself nearly every day over the prior 2 weeks. Upon further inquiry, the patient confirmed that he did have thoughts of self-harm, but he was ambiguous on whether or not he had a plan in place to actually follow through. He lived alone, didn't have any support system, and his family lived out of state. During the conversation with the patient, the exercise physiologist started a Skype conversation with one of the cardiac rehab nurses while the patient was still conversing. We did go ahead and identify the patient's physical location, and we also offered him a law enforcement welfare check, although he declined. We ultimately made the decision, however, to proceed with contacting 911 due to him reporting suicidal thoughts, and we continued the telephone conversation until we could verify police officer presence. The time of the call with the exercise physiologist was about 54 minutes. So the patient was transported via ambulance to the emergency department. There, he reported to staff he was overwhelmed by medical issues and related financial concerns. He mentioned that he recently lost a job and did not have any medical insurance. He was even having difficulty with performing daily self-care tasks, and even recently told his family goodbye as he felt he was dying. Sadly, in the emergency department, he revealed to the physicians he did intend to commit suicide by jumping off of his 3rd-story balcony. He was voluntarily admitted to the psychiatric unit with the diagnosis of major depressive disorder without psychotic features, this being the initial episode. He was severely malnourished, and his hospitalization was complicated by a bradycardic episode secondary to a coughing spell. Because of this, he needed to be transferred back to the emergency department for further evaluation where he was stabilized. And he was offered additional psychiatric inpatient care, but declined. He was ultimately approved for discharge from psychiatry because he said his suicidal thoughts had essentially resolved because his health concerns were at that time being addressed. No new medications, including psychotropics, were started. And his total time of stay was about 24 hours. He had outpatient psychiatry follow-up scheduled, but no showed. In subsequent calls with the exercise physiology team, he reported he was medication adherent, although again, no psychotropics were initiated because he declined these. He still wasn't performing any structured exercise, but was participating in frequent activity of daily living related walks. He was also prescribed an appropriate progressive aerobic resistance and flexibility program. And he ended up completing 4 sessions of home-based cardiac rehab before transferring back to a local program out of state closer to his family. So I think it's important to acknowledge that this is a patient who would not typically be eligible for cardiac rehab if not for the public health emergency, which allowed patients to enroll earlier than the 6 weeks because the sessions were essentially not charged. So although it was unfortunate to find ourselves amidst a public health emergency, This was actually a scenario where a patient greatly benefited from the exceptions we were able to make. I think it also highlights the question of how many other patients have experienced or will experience something like this. As a result of this case, the home-based cardiac rehab psychosocial workflow was revised. Up until this time, we were sending the depression screener via portal, but we didn't want to risk an elevated score going unnoticed for several days. For example, if it was sent on a Friday. So now these are completed via direct conversation only. We also redefined the workflow to help serve patients struggling with anxiety and depression. And ultimately, I think that psychosocial support in cardiac rehab is essential and warrants further development. In Rochester, at least, we're fortunate enough to have an outstanding network of resources that we can refer patients to, such as our main speakers today, who are really an asset when it comes to helping cardiac rehab patients optimize their psychosocial status.
You're muted.
There you go. So thank you so much for the invitation to be here. Excited. I'm just going to do the first part of our talk on role of mental health support in the ambulatory cardiology clinic, and I have no disclosures. So hopefully after today's talk, you'll be able to review psychiatric syndromes and areas of psychological distress identified in patients with cardiovascular disease, identify psychosocial risk factors, also commonly identified in this population of patients, as well as how these associate with illness experience and outcomes, be able to summarize diagnostic tools, pharmacologic, non-pharmacologic treatment strategies available, and recognize the importance of having multidisciplinary team approach for this population of patients. For the 5 questions, I actually included a link in the chat where you can review all questions and options, and we'll go over this at the end. So the first thing I wanted to start talking about is the normal reaction to stress versus depression, which is actually common in patients with cardiac illness. So there actually been a set of things identified in patients who are acutely ill with a cardiac condition. And things include sense of shock, worry, guilt, anger, irritability, sense of confusion and forgetfulness, even pessimism about the future. And this can be tricky because a lot of these overlap with depression. When these emotions are transient, they're referred as cardiac blues, as defined by a group in Australia, or homecoming depression by others. And they should resolve, and it's important for us to educate patients about that. But we know that there's a group of patients who don't get better, and they do present a depressive illness. And these are the things that have been characteristic to these patients: lower fluctuating mood, sadness, loss of pleasure or withdrawal, and reduced self-esteem. So the connection between the heart and brain is existent since ancient times, and we've been refining that for some time. And now we have a potential pathophysiology between depression and cardiac events, including biological mechanisms and some behavioral mechanisms as well. So let's go over some data on depression in coronary heart disease. So we know that those with stable CAD, unstable angina, and myocardial infarction, 31 to 45% of patients present clinically significant depressive symptoms. And 30 to 50% of patients score above threshold on self-report depression measures in the post-ACS period, with 15 to 20% of patients meeting criteria for major depressive disorder. So I would make a comment that it's important for us to keep eyes on these high scores. However, it is crucial to repeat scores when we are screening, and then be cautious about translating this into immediate diagnosis. Depression history is very important, and we know that history of a major depressive illness increases the risk of negative outcomes after MI. And recent data actually shows that recurrent depressive symptoms is associated with inflammatory markers. Depression, of course, increases the risk of non-compliance with medical treatment, including lower participation in cardiac rehab, in particular, those patients who have severe depression. And additionally, depression has been identified as a risk factor for cardiac events. And there's actually more than 200 studies on this topic. I'm going to just talk about one of the largest meta-analyses, including 29 studies, comparing patients with depression and without. And those with depression were at increased risk of cardiac-related death, increased risk of all-cause death, increased risk of cardiovascular events in 2 years after acute MI. And of course, there's questions about what's the role of cardiovascular risk factors and severity of heart disease. And we know that likely the relationship between depression and cardiovascular illness is bidirectional. But a lot of studies, more rigorous studies, have been done taking into account these things. And even then, depression continues to be an independent risk factor for outcomes. So to that end, in 2014, the American Heart Association declared that depression was a risk factor for adverse events following an acute coronary syndrome. So let's look a little bit about how depression occurs in these patients. So one important thing to keep in mind is that depression can dissipate over the following 4 to 6 months, independent of disease severity or cardiac rehab participation. There have been some risk factors identified in this population that includes young, lower family income, people with history of anxiety or depression, those living alone or having lack of social support, those who have comorbidities, in particular diabetes, and those who have had a recent loss. Patients with chronic or delayed symptoms are at increased mortality risk, and actually patients can have depression develop even 6 to 12 months after an acute coronary event. There was actually a study done in Australia looking at patients after myocardial infarction and surgery with a 12-year follow-up, and they found that those patients who had depression in the hospital that persisted over time had 64% mortality rate as compared to those whose depression resolved over time. So if we look about the severity of depression in this population of patients, the vast majority of patients don't present with depression. A lot of them also have mild depression, and I would argue that a lot of those mild are not even depression, but other areas of psychological distress that are hard to identify. But still, we have up to 26% of patients who do have persistent depression, and 4 to 9% of patients who have actually severe depression, and we need to keep an eye on those. The other problem with depression is suicide. So the highest suicide rates in the United States are in those older than 50. That not only patients start acquiring illnesses, but there's also financial changes, retirement, and things that increase their suicide risk. And we know that physical illness is a risk factor for suicidal ideation and attempts, in particular in patients who have multiple comorbidities. There was a study actually done in Denmark that found that after MI, there was increased risk of suicide that would be sustained even 5 years post-event, with the highest risk being in the first year, in the first month post-discharge, and the risk being 64 times greater for those with a recorded history of psychiatric illness. So again, identifying those patients at risk and that have a psychiatric history is really crucial. And what other things contribute to depression? And there's been studies, both quantitative and qualitative, to assess for this. And the first and probably most common one is loss and grief. And patients describe things as gender roles, sexual intimacy, and self-worth, but also illness perception. So those patients who think that the illness is gonna be with them for a long time, will not be cured or resolved, tend to do worse. Sexual dysfunction. So around 10 to 54% of patients don't resume sexual activity. And there's psychological components to that. That includes depression, fear of causing a heart attack, and anxiety. So it's important for us to think about exploring this and doing sexual counseling and pharmacologic treatment when available. And then cognitive dysfunction. So we know that cognitive impairment is often a source of depression and anxiety. A recent study done in patients with MI found that they do have reduced executive function as compared to normative data, and that depression actually was associated with lower scores. If we think about those who undergo CABG, around 50% of patients will report some cognitive difficulties, and 20 to 46% of those actually had cognitive performance problems before surgery. So because depression has been so important for this field, there's been a number of trials done to treat it. That includes antidepressants, psychotherapy, particularly CBT, and other models like collaborative and step care models. So all of these have shown to improve psychological scores in the short term, but actually none have been able to improve cardiovascular outcomes except for the blended care approach. And these are collaborative care models that have care managers who target both psychological and cardiovascular symptoms. And those have been able to improve cardiovascular risk factors, particularly glycemic control, cholesterol, and blood pressure that actually sustain during follow-up, which is pretty promising. When we think about anxiety, actually the relationship is a lot less clear, but we still know that 20 to 30% of patients experience elevated levels of anxiety after an acute coronary syndrome, and 50% continue with symptoms even 1 year after the event. However, data has not been able to demonstrate that anxiety is associated with negative outcomes. And a lot of the studies more recently had shown that that relationship is really attenuated by depression, which is not surprising since depression and anxiety actually are often comorbid. One quick note about panic disorders: around 20% of patients who arrive to the ED with chest pain meet criteria for panic. So it's another important thing for us to recognize because it's a treatable condition that we can help patients with. But depression and anxiety are not the only areas of distress in this population of patients. We know about mental stress, both acute and chronic mental stress, with good data about association with negative outcomes. Trauma and PTSD, both MIs being putting patients at risk for developing trauma, similarly transplant, but also patients who have PTSD having greater risk of major adverse cardiovascular events. Vital exhaustion, which includes unusual fatigue, increased irritability, and demoralization, has been consistently associated with negative outcomes, including all-cause mortality. And the last that it's actually been I would say the least promising is the type A behaviors and type D distress personality. Those actually have not had such important data. If we look at other population of patients, so in heart failure with depression, around 22% have clinically significant symptoms, and 19% of patients with heart failure present with a depressive disorder. And of course, depression matters because they make patients be non-adherent and then have worsening illness, progression, and new events. Anxiety, 30% presenting clinically significant symptoms, with 13% presenting an anxiety disorder. But again, the association seems to be mediated by depression. Those with who undergo CABG, depression can present in up to 37%, and 4% can actually have moderate to severe symptoms. I will make a quick comment on delirium because it has a high incidence on this population, and sometimes delirium can persist over time, and we get to see them in the outpatient setting. And then in the heart transplant world, depressive symptoms up to 63% of patients, and 26% presenting anxiety disorders, which tend to be more common in the first year post-transplant. So let's now look at some of the positive things or things that could help patients do better. So one is optimism, and there's been kind of consistent data showing that optimism actually helps patients engage in healthier behaviors. It also lowers cardiovascular risk. Self-efficacy is another one, improvement in exercise confidence, but also helping them sustain positive behavior change. Social support. So we know those patients who have social support tend to overcome barriers to lifestyle modification. And those who live alone or unemployed tend to actually be at increased risk of developing depression after an acute coronary event. And self-esteem. So those patients who have low self-esteem tend to have low coping resources and do worse and be at increased risk of psychological symptoms after stressful events. So because all of this, in 2008, the American Heart Association recommended kind of universal screening for cardiac patients. And there's been a lot of debate about screening, but I would say that for routine screening to be useful, there has to be effective management protocols in place, and availability of well-trained professionals provide psychological and psychiatric care for our patients. There's been a number of scales used for screening. However, the PHQ is the most common one, with recommendation to start with PHQ-2, and if positive, to move on to PHQ-9. Now I'll just make a quick comment about the item 9. So I was actually able to look at this in a group of close to 400 cardiac patients. We had a 21% positivity of the item 9, but when we follow up with our detailed suicide evaluation, around 0.5% of patients really needed psychiatric care. So as a result of some of this work, there's been question about the utility of PHQ-8, and the data is actually good, showing that PHQ-8 is able to detect major depressive episodes very similar to what PHQ-9 does. There are also cardiac specific scales, in particular for cardiac rehab, but there's one that I wanted to show today, which is the STOP-D. It's a screening tool for psychological distress. So includes some depression, anxiety, stress, anger, and social support. And I like it because it helps us not only focus on one part of psychological distress, but actually evaluate patients in a little bit more broadly and be able to assess other areas that may be affecting these patients. And then along those lines, a group in Australia who's done a ton of work in psychocardiology actually developed the term cardiac distress as a persistent negative emotional state rather than a transient state involving multiple psychosocial domains that challenges the patient's capacity to cope with living with their heart condition, the treatment of the condition, and the resultant changes to daily living, and challenges the person's sense of self and future orientation. This is similar to what oncology has done with cancer distress, and I think this is a move in the right direction, hopefully helping us identify more patients who struggle and then develop treatments targeted to those. But identifying distress in patients is really hard. First, there is somatic symptom overlap. So fatigue and appetite change is often present in both psychological syndromes as well as cardiac. The severity of depression is hard, in particular those who have mild symptoms, because it's unclear if it's their normal reaction or is it something more. The anxiety comorbidity is challenging because it also will have additional symptoms, but it also makes treatment more challenging and less response to pharmacologic agents. Patients often have denial, and that masks symptoms, and that doesn't help with adherence. And then lastly, not having good understanding of psychological distress symptoms and ways to explore this in a way that's helpful for patients. So I would say in summary, I think screening is valuable. We just have to be careful of kind of what we have established for follow-up, and it's always crucial to repeat that screening. For depression and anxiety, PHQ, GAD, and the STOP-D that I mentioned, but important to really identify risk factors to know what patients are at highest risk. I would also say that it's important to screen for PTSD and trauma, and there's actually also risk factors for PTSD that we should be looking at. I think cognitive status screening is crucial. We have to look at a number of differential diagnoses for both depression and anxiety, as well as evaluate coping styles and triggers. I would say that repressive coping style can be actually bad for patients, and then looking at the positives, right? Optimism, resiliency, and social support. I'm not going to go into much detail about non-pharmacologic treatment strategies, but it'll start with education, exploring illness perceptions, and other areas there, including therapy, but Kelly is going to do good conversation on this. And then there's a lot of room for pharmacologic treatment when patients meet criteria for that. But I really can't emphasize enough that multidisciplinary team approaches, hopefully collaborative and blended care models, are really the best way to help these patients succeed. Thank you.
Thank you for inviting me, Dr. Suarez. It's been great working with you these last few months and just organizing this topic. And I think it's such an important topic for us to be talking about and working with. As Dr. Suarez illustrates the importance of the psychological distress with patients with mood dysregulation and the context of patients with cardiac challenges, I want to talk a little bit about the predictors for depression and anxiety and the benefits of how psychological care can impact recovery, and suggestions for what to expect or when to suspect for mood-related challenges or other psychosocial challenges that occur. I have no disclosures. Now, let me see here. Okay, no disclosures to report here. We know that patients experience worse emotional functioning after a cardiac event, whether that cardiac event is a heart transplant, whether it's a valve repair, whether it's a sudden cardiac arrest. And we know that research tells us that these patients, their functioning can overall be affected to include mood variations as well as struggles with finances, social and peer relationships, family relationships, neurocognitive deficits, loss of self, post-traumatic stress disorder, and several other listed factors that I have noted here. We also know that at most, if not all of our patients are typically successfully engaged in full adult responsibilities and roles prior to their event and do experience these specific psychological challenges that may impact emotional functioning for a period of time as they recover. Patients, as Laura mentioned before, are really presented with this shocking news of a cardiac condition and an unfortunate experience of a cardiac event or intervention, which invokes a lot of stress and can create a bit of panic. Patients are presented with large amounts of information at that time they are presented with a large amount of information in a very short period of time in order to manage and make plans. And, that can be extremely challenging, but I feel so much of our role is there to help maximize their understanding for favorable outcomes. So essentially, I think by working together, our goal is to achieve that optimal patient outcome by helping patients with recovery needs to successfully overcome psychological and behavioral limitations that can be prompted by either experience. So I'm going to start, I'm not going to be able to go through all of these. There's just too many. They all deserve a lot of attention, but I'm just going to talk about a few of them. I'm going to start with impaired coping. And what we know about impaired coping, this can include a lot of anger and frustration as one navigates recovery and an inability to effectively utilize positive coping mechanisms. Maybe the patient did not have good positive coping mechanisms previously. This does become noticeable, I think, when we're working with our patients, as they may start talking to us a little bit more about things that are going on. We should be able to see some of that demonstrated by the mental health instrumentation through the GAD-7 and the PHQ-9. And again, commenting to and agreeing with Dr. Suarez that the PHQ-9 can be skewed by physical health symptoms, particularly with cardiac patients. So the tools do require further evaluation, particularly when the symptoms are elevated. The grief and loss, particularly that patients experience, can be very challenging, and rehabilitation following a cardiac event can be intense as well as lengthy, particularly if the patient is also requiring additional rehabilitation for a cognitive impairment. It is very common for patients to experience grief as they process towards acceptance of their situation. And with that road to acceptance, there's a lot of bargaining and anger and denial, I think, that goes on during that time. Another factor, loss of self, loss of identity, may follow a significant medical challenge as it impacts vocation, family role, where one sees them in the family, and basically an overall deep sense of personal loss. It becomes important to understand how the medical compromise impacts these changes and how it impacts coping. Are they struggling with post-traumatic stress disorder? Are they engaging in risky behaviors? Are they socially withdrawn? Are they non-adherent? So those factors do play a role. Social isolation can be particularly challenging for people who are already isolated prior to illness. And the social isolation can affect access when health symptoms decline, as well as mental health symptoms decline. Essentially, adherence to treatment is affected when these psychosocial factors are stressed and not addressed and may require more emergency medical visits. So essentially, if we've got patients who are socially isolated, they have limited support options, they may not have family locally, they may even be conflicted with their family members and they don't even know how to ask for help. So that is something that's interesting to find out prior, kind of what their resources and supports were prior to an event and how we can maximize the use of their supports throughout their time. Post-traumatic stress is associated with adverse outcomes and increased mortality in cardiac patients. Essentially, PTSD is an anxiety disorder marked by the onset of symptoms after an exposure to a traumatic stressor. It is associated with an increased risk of recurrent myocardial infarction, hospitalizations, and increased mortality in cardiac populations that Dr. Suarez has also mentioned. I just want to make a note. There was a patient that we all worked together with, and I was initially consulted in August of 2020. We worked together, I think, until about December or early January 2020, 2021. And I recently, well, I shouldn't say recently, I started hearing back from her in August of 2021, and I'm working with her now just on some post-traumatic stress. So, you know, it's interesting, the triggers, you know, that encourage some of the panic for patients with, you know, who are experiencing post-traumatic stress disorder. And that's exactly what she was experiencing as she was coming up on the anniversary of the event that she struggled, you know, that landed her basically with us through cardiac rehab, and then with mood dysregulation during that time, and then you know, working through that. You know, she was actually doing quite well for a good period of time up until the anniversary time. As Dr. Suarez mentioned, sexual problems are highly prevalent. I will make an addition that it's in both, you know, it's also with the partners who have equal and greater concerns at times. Therefore, inclusion of the patient and partner is equally important. Pharmacology, as Dr. Suarez mentioned is a great opportunity and an option for these patients, as well as potentially working with a therapist. And socioeconomics highly impacts mood and is known to increase anxiety and depression. We know that financial barriers contribute to non-adherence as to essential medical therapies and health recommendations, which lead to adverse patient outcomes. These barriers include access to medications, cardiac rehabilitation and exercise, psychological support, and transportation. And so what do we do about this? I mean, this is really a nationwide problem. And I think one of the things that we're able to continue to work with on patients is education, integration within our community supports, getting family members on board to help enhance self-advocacy and self-navigation of skills necessary to kind of complete the need for resource acquisition and such. There's, you know, looking towards local support options. What is their support system within the family, outside of the family? That could be church or community-based supports as well. We don't have great necessarily options sometimes locally from our like Olmsted County resources, but at times they can come through with waivered services for patients who have more high needs at home that require like support staff such as nursing or just more frequent checks that might fall into a more at-risk category. So typically, as I am working with patients and you're sending them my way, I have this opportunity to begin this therapeutic process for support at a critical time, which can enhance that positive trajectory to recovery. So evaluation, mental health screening, and treatment planning are the foundation for that psychotherapeutic relationship. And I want to just point out here that it's really interesting for me to find out what that patient perception is of the current circumstance. What are their current feelings of the situation that's happening? What's their cognitive status? And I really do want to know what their previous goals in life were like, and how do we readjust and create new and current new goals, essentially to help them. I have got to forward here. Okay, there we go. Sorry about that. And so essentially just kind of going through and, you know, looking at these types of things are really helpful. Really getting a good understanding of the global medical, the psychosocial history, and their personal history, academic, occupational, social. Okay. Mental health management, it includes that psychosocial assessment, goal planning, treatment plan, ongoing reassessment, utilization of clinical treatment interventions, and ongoing collaboration with a multidisciplinary team. All right. And I want to just talk a little bit about the clinical treatment interventions. So the use of cognitive behavioral therapy is really important and a great treatment intervention to be using with our patients. Basically, mental health providers, we work to essentially restore the cognitive and behavioral and social functions of the individual. And our focus really is on addressing variables such as denial, lack of awareness, defense mechanisms, and effective reactions associated with that recovery. So CBT, cognitive behavioral therapy, really helps identify situations. We call them triggers. So if we kind of think back to the example I gave with the mutual patient we have who was having some PTSD, her trigger was the anniversary date of her cardiac arrest. So basically being able to recognize that as a trigger was helpful for her to kind of work through and kind of manage some of her thoughts and challenges that she had been kind of creating kind of unknowingly about that bit of trauma for her. So essentially we want to teach and we want to use different skills to help a person shift a distress cycle into a coping cycle. This includes the use of mindfulness, relaxation, and behavioral activation, and obviously the use of cognitive behavioral therapy. All in all, the goal is to actively change a behavior to increase a person's sense of confidence and security. Essentially, cognitive behavioral therapy remains an important aspect of recovery. At the same time, the individual needs additional supports to include individual and group modalities to address psychological symptoms, understanding insight, and positive and effective responses, and coping skills. Okay. Some things that we can utilize during our time with patients. So these considerations can be basically practicing from a perspective of patients with the patients that we're working with. And I'm sure we're doing this every single day, engaging the patient and the family as active participants and encouraging normal routines and activities. So allowing the patient to share and talk about the event is helpful for processing purposes and exposure to the event. Talking about the event aids in moving through the experience rather than around it. This also lessens the effects of PTSD. Additionally, normalizing routines empowers the patient towards independence and confidence and security. All right. And Dr. Suarez touched a bit on this, the cognitive impairment versus depression. This is actually a really important part of kind of the recovery. As you know, it is important to be able to decipher whether the patient is suffering from a cognitive deficit or depression. This consideration is determined by a thorough assessment of the patient with neuropsychological results and collaboration with the medical team. Lack of drive, lack of emotional reactivity at first glimpse may be explained as a diagnosis of depression, but at the same time, these symptoms represent what is called pseudodepression in those with an acquired brain injury. In addition, apathy toward treatment should not automatically be assumed as resistance or depression or hostility, as it may be more neurologically based. So we know that the neurological side effects associated with the cardiac event places survivors at risk for adverse cognitive and behavioral outcomes. These issues contribute to a reduced quality of life in patients. And it's also important to understand and engage the patient and the family as active participants in the normalization of routines to assist in restoring the patient's sense of self and develop a new acceptable identity. And I'm just going to skip over that one right now because I know I'm running a bit over here. And I think probably the one that I want to talk about next is, mood dysregulation. When do we suspect, when do we refer? And I like to kind of call that the 4 asks, and essentially ask, inquire directly about well-being with the patient. What does it look like? What's their quality of life? Advise, offer guidance on coping and expected challenges, normalize the process. Is the patient experiencing significant distress? Assist the patients by providing support, education, and strategies that have helped others. Arrange for a referral to myself or for other local supports that maybe the patient already has connection with. Some patients really respond favorably to the opportunity for mental health support, whereas others may decline this for a variety of reasons. Some still identify with a perceived stigma with mental health, and others may have financial barriers or wish to manage and address their psychological challenges without professional help. So overall, maintaining an open dialogue about mental health and quality of life since a patient will assist with the patient's improvement and ongoing recovery as we are working with them together. And the last slide that I want to just go over, I have some information on caregiver stress. I'm always happy to talk about that with people if they have interest in that. Essentially, a variety of health professionals, are great to collaborate with. Exchanging of information is very helpful. Transition readiness for the patient is something that we can continue to work on and work together on, understanding the knowledge, understanding the diagnoses and treatment, potential late effects and surveillance recommendations, identification of primary healthcare setting and providers, and that ability to help make and keep appointments, follow healthcare recommendations, keeping them compliant, essentially. And during this time, we can continue to assist with those transitions, the readiness, and continue with education to empower our patients to be resourceful and and also to identify those resource deficits. Thank you.
Thank you very much to all of our speakers. At this time, please feel free to send through questions through the question and answer area or the chat area. And maybe we could start with Dr. Suarez-Pardo's 5 questions if we want to go through those first.
Yeah. Would it be okay for me to share the questions? Let me just quickly do that so we can look at them.
I think too, as she pulls them up, any people that we have today from the different enterprise sites that maybe have a different experience than Rochester with the resources available, I think it'd be really great to hear from your workflow and what you're able to do.
Okay, so the first question we had, it's about what's the most common psychiatric syndrome in patients with coronary artery disease, heart failure, and I will add that in general with the cardiovascular population, it's depression. What are the aspects that help differentiate between normal reaction to stress and depressive illness? And the ones that have been consistently shown in research are low mood, sadness, loss of pleasure, and reduced self-esteem. What are some protective factors for psychological distress in patients with cardiovascular disease? Optimism, strong social support, and self-efficacy. And I would add that there's actually ways of measuring all of this if we want to do it quantitatively, which is also helpful, as well as targeted treatments. What is true about screening patients for depression and anxiety? So it's all. So management protocols and multidisciplinary teams. Screening doesn't really impact cardiovascular outcomes. However, it can help psychological symptoms, and screening should be repeated after acute event. And then last, what characteristics of psychological distress warrant a referral to a mental health provider? And the ones that been consistently showed severe depression and history and persistence of depression that doesn't really recover. Of course, those patients who do have severe symptoms of PTSD or trauma and that may benefit from pharmacologic treatment should also be considered for that.
Wonderful. Thank you for reviewing those. The questions are just pouring in. So if anybody has any questions or thoughts, or maybe a patient case that they've recently dealt with, happy to discuss those. Also, I really appreciate Dr. Suarez highlighting what we can do, the positive side of it. So maybe I'll call on Adam since he's the one here. Is there anything that you can think of in the realm of, say, like optimism or increasing self-esteem or self-efficacy that either we do currently or that we could potentially add?
Yeah, thanks. I think that a common thread for a lot of cardiac rehab patients is a sense of helplessness, even perceived disability, fragility. And I think, especially when we meet with them early after discharge, they're able to get a large boost to their self-esteem when they're able to see what they are able to accomplish. And for us, it happens to be exercise in our arena. Others will be different, of course. But I think they surprise themselves, and also it's very reassuring for their family members to see that. So at least from our perspective, that's something that we're seeing that's really motivating for patients, and then us as practitioners too.
And if it's okay for me to add one thing, I think it's probably something that you already do, but cardiac rehab is a source of support. So sometimes helping patients understand that some of the resources we offer is part of their support system that's going to help them in the long run. Sometimes they feel like it's another chore, we have to do this or that, but it's just sort of helping them understand that it's just building them with support in the hardest part of their recovery. And that actually can help them a little bit with things.
Yeah, pulling together what has been mentioned, Kelly highlighting the need for patience with our patients, that we do have a lot of resources available, but, we hear frequently that it is so overwhelming. The event was overwhelming, the hospitalization was overwhelming, and now starting rehab is overwhelming. So having the patience to continue to offer those services, even if they're not ready for them on day one, but that they're available and that we can help. Kelly or Dr. Suarez-Pardo, any further comments or thoughts to add on, the benefits to our program, or anything more that we could add?
It's a pleasure working with you all.
I can have maybe a question on maybe some advice I'd like to get from Kelly and Dr. Suarez. As you mentioned, Kelly, there unfortunately tends to still be a stigma associated with seeking either social work care or psychiatric care. And as you mentioned, sometimes there's less than ideal acceptance to get those, even when we refer. And so one of the things I say is, well, we're looking to optimize well-being. A lot of what we do is optimizing physical well-being. So I try to paint it in that way, but I don't know if there's anything that you would recommend or verbiage that you might advise that we use that more accurately summarizes what they can expect from you, or that is maybe a little bit more favorable.
Yeah, I think that it's definitely, it's something we continue to work through and practice within the clinic. And how do we normalize the discussions of mental health wellness? And I think the more we talk about it, I think the more accepted it becomes. And I think just to really normalize that process to the start, working in the congenital heart clinic, I know that it's I've been here now about 2.5 years. So, it continues to be a discussion about, what is it that I'm doing? Why am I here? What is this about? And it's really, I like to talk about it as a really holistic approach to care. So we know that there's not really great, physical care can be impacted if the mental health is not good, and mental health can be impacted if the physical health isn't good. So we really try to approach it from both angles. And really just really talking about it and kind of in normalizing that process. I think a big part of it too is when patients hear their physicians talking about it, it almost, I think, encourages them that it is a normal process, that we do have to pay attention to the mental health with our patients. And I think also just noting too that we know that our patients are at much greater risk, our cardiac patients, for mood dysregulation just at baseline, and really normalizing that process, or that whole, just fact, the information.
I think also encouraging providers to talk about it. I think what Kelly was saying is super helpful. There was a group in Australia who actually surveyed their patients. They will give a pamphlet about mental health symptoms after cardiac event in the hospital. And they surveyed the patients to ask them, was it helpful? And overall, they really liked it. But what they were wanting is more information from providers. They wanted the information to be verbalized during the appointments and talked about. Of course, the written education is helpful, but I think we have to model that sort of normalization of symptoms. And oftentimes people will do things like, let's call it stress and maybe not the word depression. And I argue that's somewhat helpful, but we want to work in helping patients understand that depression is a disease and that we have to identify it when it happens. So we have to begin the conversation and sort of meeting patients where they are, but then moving it forward as much as we can. And I think we as providers can really do a much better job.
That's really great. Well, I'll say thank you again to all three of our speakers today. This was a wonderful presentation. Thank you for joining us, and everyone have a wonderful day.
Thanks.